So I get started here so we can keep on time. So it's my pleasure to introduce Dr. Amy Bauer, who's going to be giving our grand rounds today. She comes to us from our own department where she's an assistant professor, mostly located over at the medical center proper. So Amy actually came from the East Coast where she did a residency at MGH and then a fellowship in psychosomatic medicine. And her primary research interest here is, wow,
That was fun.
her primary interest is rave dancing, and that's what we just heard. Her primary interest is mental health disparities, and specifically how these can be addressed in underserved populations in primary care. And today she's going to tell us a little bit about her research involving technology and how to apply this to help this population. Thank you.
Thank you so much. I'm really pleased to be here and want to thank you for inviting me to come down. So in terms of the ground that I'd like to cover today, I'm going to begin by talking a little bit about why there's so much interest in technology and mental health care these days, and give you what hopefully will be a little bit of a tour of some of the different ways that information technology and communications technologies are being applied in healthcare generally, and in particular of interest to us in behavioral health. And then want to show you some of the emerging evidence for some health technologies with a particular focus on mobile health technologies, which is an area of interest to me, as well as raising some of the limitations of where we are today. I think we're just at the beginning of this field, and so we have a little bit of evidence and a lot of limitations. And then I want to move towards the end to talk a little bit about some thinking that I've been doing in particular about how to align our health technologies with models of effective service delivery so that we really can get the most out of the technology and that we're smartly applying the technology in service of the things that we all do to try to work with our patients and improve their lives. In terms of some of the context about why technology is on the radar screen these days, there's a number of things that have happened recently in terms of federal policy in this country, including the High-Tech Act, which was passed as part of the Recovery Act, which invests $26 billion to try to push the use of electronic health records and health information technology. And right now we're in the middle of the staged implementation of that process. And the criteria that we've all heard of, meaningful use of health information technologies, has been moving forward, and the direction that this is taking is that in the third stage, which will be implemented in 2 more years, involves patient use of health information technology. And the full vision of this is that once fully implemented, health information technology is supposed to support things that most of us probably believe are important in improving population health, which is population-based care, care coordination, empowering patients, improving quality, and improving patient outcomes. And so altogether what this means is that we're beginning to be at a place where health information technology is not just about the tools that providers might use in an inpatient setting or in a clinic, but that we also are starting to engage patients in using health information technologies, and we really need to think about how to bring together technologies that patients use and technologies that providers use so that we can have a really smart way of exchanging information and using this to our advantage. So in addition to federal policy, well, I'll step back and just say for a moment, in terms of health information technology, we all think about electronic health records, but there's a lot more going on. And so health information technology in general can refer to the application of any kind of information processing kinds of computer hardware and software, which might include personal health records, it might include registries of patients that we can track, and it can certainly include a lot of work in remote monitoring and other technologies. Within health information technology, generally we have mobile health, which really focuses on mobile or wireless communications. And that's not just what your cell phone or your mobile phone can do for you, but also a whole host of other kinds of tools that can be used in patients' homes, and wirelessly transmit information back to healthcare systems. So there's a lot of action in that arena as well. So we're now at a place where there are 6 billion mobile subscriptions around the world and 1.75 billion smartphones. And what this means is that we have populations in places around the world who have a phone who do not have any access to healthcare. We can reach more people through communications technology than we can through existing healthcare systems. And in the United States, smartphone adoption is actually greater among ethnic minority populations than it is among whites. So what we're seeing is the opportunity to try to reach populations who have traditionally been underserved or who cannot access traditional health services. With the rapid adoption of technologies like mobile phones, we're starting to see the application to health. And so in just the last couple of years, the number of mobile health applications that are available directly to consumers for download has really taken off and gone from something that didn't exist about 5 or 6 years ago when smartphones were really just starting to come onto the scene to something that's practically ubiquitous. When we think about what you can do with a mobile phone to improve health, you can think about a number of different ways you can use a phone. So at its most basic, mobile phones, when they were first developed, came along the lines as a communication tool, and we can use those in health services ways to try to connect people better with existing service systems and use the features as a phone call, as a text message, to provide patients with reminders for their appointments or for medications. We can also use them to help with symptom reporting or monitoring, which can be done, through the telephone, but also through things like interactive voice technologies or in automated ways. And then a few years ago, the cell phone turned into something that looks more like this, which is a powerful computing device in the fingertips of people all over the country, all over the world, really. And that opened up some new opportunities. So now we can use this as an intervention platform for clinical applications, which could include things like apps that have self-help or automated interventions. An example of this that many of you may have seen is the PTSD coach, which has symptom monitoring and tracking, and then also offers suggestions about brief behavioral kinds of interventions that people can do on their own entirely in a self-help way. But mobile phones also have other kinds of features that can be leveraged for healthcare purposes and offer the opportunity to use them as measurement tools themselves. So things like the GPS that tracks where you are, we already know that can be then used when you are looking up directions or trying to find out how to avoid traffic to get down to Harborview Hospital. And those same kinds of features can also be applied in healthcare arenas. So the sensors in the phones, like the GPS and accelerometers, as well as light sensors and other kinds of sensors that can detect your psychomotor speed through how fast you're keying things in, can be used to infer things about people's behavior or potentially mood. And I think that's a new way that we're starting to see mobile phones being used and applied in the healthcare arena. So these are some devices that are either currently available or will soon be, or are under development and will soon be available for consumers. And what we see is that there's a real move towards having very small sensing devices that are incorporated into our eyewear, our contact lenses to monitor glucose and potentially have implications for diabetes management. Things like cameras embedded in a button in a shirt, which can take a picture of what you're eating and do some nutritional analysis. Activity monitors I think are big. There's a lot of wristband devices, the Nike Flex and the Fitbits. And you can imagine that it won't be long before that goes from a wristband to being woven into the fabric of your clothing. So we're at a place where there's all sorts of devices that can be telling us about ourselves and about our environment. And these are now being applied in behavioral health ways that I think open up some very potentially interesting avenues that we can go. This all seems a little bit far-fetched, but what I'm showing you here is current eHealth challenge from the National Council for Community Behavioral Health Care, where they identified these 6 different technologies, and I think are announcing a winner next week or so, around how some of these kinds of tools might advance behavioral health care for the patients that we care for. I often hear questions about the idea of this virtual therapist and when will we be replaced by computers, which I think also is a bit of a far-fetched idea. But just to give you an example of what some people are thinking in this space, this is a virtual therapist that's been developed by some engineers at USC. And so what I'll try to do is give you a little taste of what she can do.
Hi, I'm Ellie. Thanks for coming in today. I was created to talk to people in a safe and secure environment. I'm not a therapist, but I'm here to learn about people and would love to learn about you. I'll ask a few questions to get us started. And please feel free to tell me anything. Your answers are totally confidential. Are you okay with this?
Yes.
So, how are you doing today?
I'm doing well.
That's good. Where are you from originally?
I'm from Los Angeles.
Oh, I'm from LA myself. When was the last time you felt really happy?
When was the last time? I don't know. Yeah. I'm not someone who's really like, I don't have any real highs. I feel like I'm a level person. It's just happy. I guess to answer your question, probably a couple months ago.
I noticed you were hesitant on that one. Would you say you were generally a happy person?
So I wanted to use that as an example to show how there's some really smart things that are happening that are bringing together fields like computer vision and natural language processing to try to perform a virtual mental status exam. They're looking at patients' speech, their movement, characteristics about their eye contact, and using those to inform how this virtual agent can then interact with somebody. And I think the question isn't, is this about to be the thing that's going to drive us out of business? But I think the real question here is, if they can build it, what could we do with this? How could we use this? I don't think that necessarily is going to be a 50-minute therapy hour, but you could imagine that this kind of tool could be very useful if we think smartly about what are things that we can't do face-to-face right now, where we might be able to get some more information or get something to somebody who is out in the community, having an emergency, maybe in a situation where there is no provider. This may be something that could help a family member or help in a variety of different ways. So I think that's, we're a long way off from virtual therapy, but I wanted to show you what I think are some interesting ways in which our colleagues in engineering and the computer sciences and data analytics are trying to put things together to create new tools for us. And the challenge will then be, where do we go with that? So I'm going to show a couple of examples quickly about remote monitoring, which fits in with mobile health and the idea of engaging patients in technology and taking healthcare out of hospital-based and clinic-based systems. And not all remote technologies require rocket scientists and highly advanced kinds of tools. So this is one example. As you can see, there's not a very slick interface here, but an example of a tool that has had quite a bit of research evidence in showing that you can improve care for chronic diseases like congestive heart failure by doing some home monitoring, asking patients a few simple questions about how they're doing, giving them some big blue buttons to push. And it also will take information that from a variety of other kinds of sensor devices at home, like a scale or a blood pressure cuff. Not super advanced, but by getting that information from the home back to a provider in the clinic, this can support care management that keeps people out of the hospital, it improves their health outcomes, and it reduces healthcare costs. There's some certainly more advanced and kind of sexy applications of technology, and so this is an example of the FDA-approved Proteus ingestible sensor. So this sensor is attached to medications. When you take your pill and swallow it, the acid in your stomach activates the sensor. It talks to a skin patch, which communicates with your cell phone, sends information to a web-based kind of portal, and then your family or healthcare providers can know if you took your medication. So that's FDA approved, and it's out there. So if you think it would be interesting to see how that might affect the healthcare of your patients, then that's an area that we could start learning in. And another example takes this a step further and actually wires up entire living units. This is the ORC Attack platform, which was developed down at Oregon Health Sciences. And they have a variety of wearable sensors. They have computers in the home. And then they embed sensors in the house, like bed sensors. There's motion sensors in the wall. And through this can detect things like psychomotor speed from motion detection as people are walking down the hallway, or keying into the computer, and relate that to things that we think are important, like cognitive decline or fall risk. Or in the case of the bed sensors, I think they use a combination of microphones and bed sensors as a way to have a non-invasive measurement of sleep-disordered breathing. So we're seeing more of these possibilities available to us to think about how we might apply those in the healthcare domain. And with all of this happening, patients are really excited about where this is going, and they expect that we're going to have big changes in how they obtain healthcare. So the onus is on us to think about how to use this in ways that will really bear this out. And that mobile health kinds of technologies and tools will help address healthcare's triple aim of improving convenience and accessibility of care, improving quality of care, and lowering cost. I'm going to skip this. This is one of the first FDA-approved mobile health tools for diabetes management, and move on to some behavioral health applications. This is one example that I'll give you that's not in the mobile health space, but is a recent randomized trial of an electronic personal health record for patients with serious mental illness. And this is a study that was done by Ben Druss and his colleagues, in which they provided this personal health record to patients in community mental health centers who also had comorbid medical conditions. In addition to showing them the portal and how to use it on the web, they gave them some computer training and some support. And over the course of the year, what they found is that people who had a personal health record received better quality medical care, as evidenced by the graph on the bottom. You can see that the big tall green bar here is preventive services receipt. And so what we see is that by engaging patients in using some technologies to support their own healthcare and self-management, people got better care. This is a very important public health problem, and one that we really need to think smartly about how our tools can start moving us in the right direction. In terms of evidence in the mobile health domain, things are, I think, a little bit more rudimentary. And so what you see is that even with simple interventions like text messages, there's some emerging evidence that using text messages for appointment reminders and medication reminders may be effective for patients, in this case in community health mental health centers, and patients with schizophrenia. And if something as simple as a text message reminder for appointments can reduce the rate of missed appointments by a quarter, then there are incredible efficiencies that we may be able to take advantage of in doing a better job of getting services to patients. In terms of evidence for smartphone and mobile app kinds of interventions, things are a little bit earlier on, largely because it takes a long time to get research funded, and smartphones haven't been around that long. But here's one. This is a recent feasibility study using a smartphone app that was developed specifically to support self-management for patients with schizophrenia. It's a very nicely done study, 33 patients, so it's small. And the app was designed to help with things like supporting sleep, supporting medication management, addressing voices. And what they found was that patients who were given the app actually had very high use. They used this on 87% of the days that it was available, up to 5 times a day, and the majority of the use was initiated by the patients themselves. They also got prompts 3 times a day to log into the system, but they still used it above and beyond and a lot more than that. The use was not related to things that we might think would be barriers to using technology, like cognitive impairment, paranoia, negative symptoms, reading level. So they had a very good uptake of this tool. And although very preliminarily and only a month trial, they did show that people were doing better in terms of symptom scores on 2 of their measures. So this is obviously emerging. I think we're a long way from having a lot of these kinds of evidence-based tools around, but we're starting to see movement in that direction. This is a larger trial that was a randomized controlled trial of a smartphone application in patients with alcohol dependence that also just came out this year. And what they found was that after leaving a residential treatment program, people who used the smartphone application had fewer risky drinking days and greater odds of abstinence all the way out to a year, which is pretty impressive for an intervention that is on somebody's phone. I'll show you quickly one more. So this is an example of using the mobile phone's sensing capacities to develop a system for helping patients with depression. And here they're using information from the accelerometers and the GPS to try to infer things about the patient, like are you at work or are you at home? What's your mood? Do we see that your mood is better or worse when you're in certain locations? And provide some automated interventions. This is very preliminary, so that the paper that's cited was a pilot study with just 8 patients. But it does give an example about how people are thinking about using the sensing capacities of smartphones as part of intervention devices. So, given that we have limited but emerging evidence in the behavioral sciences, what about some of the limitations? Well, of those tens of thousands of smartphone apps that are available for consumer download, almost none of them have been tested or studied, and almost none are subject to FDA approval. And so we see things like this coming out in other domains of health, where some of the consumer applications that are available have inaccurate information and may mislead our patients, and we should be concerned about that. But I think that we need to also put this in context. When the internet was a new form of conveying information a couple of decades ago, there were studies that said that most of the information about depression available on the internet was wrong. And that's definitely a problem. But I think that we're a long way away from that now, and people are really able to find good health information. And we're able to inform people about how they can go about doing that. And I think there'll be similar evolutions with these kinds of tools, where we'll see things that are developed outside of the healthcare system that are not benefiting our patients. And we'll also see ways in which we can use these powerful tools to the benefit of our patients. So with this in mind as kind of the landscape, some of my colleagues and I were interested in finding out a little bit more about what patients are actually using in terms of the tools that are currently available. And we were able to look at this in a primary care population through the WWAMI Region Practice and Research Network. Last year we did a study in 6 primary care practices from 4 of the 5 WWAMI states. And we asked all the adult patients who came through for a primary care visit about their ownership of smartphones and their use of those phones for mobile health purposes. And so I'll show you a little bit about what we found. We had about 918 people who responded to the survey, who were mostly female, not too unusual in a primary care setting, mostly white. And the majority of them had at least some health literacy limitations, had at least one chronic medical condition. 21% had current depressive symptoms as reported on a PHQ-2, and about a third of them reported that they had a history of depression. And here's what we found. So among patients with and without depression, phone ownership and smartphone ownership were comparable. Mobile phones are nearly ubiquitous. Smartphones are rapidly becoming more and more common, so more than half of people with any kind of mobile phone have a smartphone. And a lot of those folks who have smartphones are using them for health purposes, about 3/4. In terms of how people were using their phones for health purposes, we saw that people with current depressive symptoms were actually downloading and using more health apps than their non-depressed counterparts. But we didn't see any differences in terms of finding health information or tracking health issues. Unlike the study that I showed you earlier, where the smartphone application was developed for patients with schizophrenia and they were using it very frequently, 5 times a day, we didn't see that. Out in the primary care world, people were using their mobile health tools very infrequently, and almost all of the use was in the couple times a month or less categories, with very few people using tools once a day or more. I suspect that this reflects that the tools that are readily available to consumers have been developed without a lot of scientific input and testing, and probably don't have as much value to the patients as things like what we saw in the feasibility study, where patients were really benefiting from them. We don't have data on that. That's a speculation. So patients with the current depressive symptoms liked some different tools than patients with, who didn't. And in particular, folks with depression were using mobile health apps for a lot of general health purposes. And they had less use of some of the really kind of popular types of apps like activity, fitness, weight, diet. Those kinds of things were used a lot less by folks with depression. That may not be surprising. One thing that we were interested in was that the disease-specific health apps like glucose monitoring, mood monitoring, that's the orange color up there. This is a tiny sliver of what people were using. Only 6% of all patients were using apps for those kinds of purposes, and none of the depressed patients were. And I think, again, this reflects what's readily available and what people are downloading. There's a lot out there in the activity and fitness world, and not a lot of really great stuff for disease management at this point in time. We also asked about how useful people thought different features of technology would be to have on their phone. And as you can see at the top, things like appointment reminders and medication reminders came out high. And there were 2 things that patients with current depression thought would be more useful than their non-depressed counterparts. Those were help with stress management and coping, and social support, which I think makes a great deal of sense. We did some additional analyses where we looked at preferences among people who reported a history of depression, but were not necessarily currently depressed based on the PHQ-2. And we found something a little bit different in terms of what they thought would be useful features. People with a history of depression thought that almost all of the features on their phone to support self-management would be more useful. They really liked all of these things. And one of the ways that I've been thinking about what this might mean is that people with a history of depression who are not currently depressed have had the experience of having to self-manage the condition and kind of get through and get treatment and improve. And so I think that this may reflect that they recognize that having useful tools to help support the things that need to be done to get through a depressive episode would be of great benefit. One thing that we don't know is whether this is actually specific to depression. So I suspect that if we broke out from our population those folks who have diabetes or who have heart disease, we might see similar patterns, that people who are living with chronic diseases have higher ratings in terms of the usefulness of how much they want to have these features available to them. Despite all the interest in using mobile health tools to support self-management, we saw very little involvement of healthcare providers. So in general, patients did not think that it was very important for primary care doctors to know about what mobile health tools they were using or not using. Only about a third of people thought that that was important. And I think that points out how little of a stake we have at the moment. We're not influencing how these tools are getting developed. We're not influencing how people are using them. They're not talking to us about it. Less than 10% of doctors overall had recommended mobile health apps to their patients, and this didn't differ by depression status. And so I think that there's a real gap there, because patients want these tools. They expect this to be a part of their future health care, and we're not really filling them in on what's out there, in part because there's not a lot of evidence, and I think we're all reasonably concerned when there's not a lot of evidence about where to go. But I think it's also the case that by getting to know a few of the things that are out there, we can be in a good position to try to help guide and advise our patients and really learn about what they're already doing. Just as we would be doing with other kinds of educational resources or self-help workbooks. Those are not all tested. They're certainly not FDA regulated, but we weigh in on those things, and I think that we should think about the digital world in similar ways. So I thought this reflected a little bit about some of the concerns that people have about bringing technology into the mental health sphere. The world is getting so impersonal. What's interesting is that there have been a few studies that have really tried to look at technology in the context of human relationships. And the first one I'll show you is an example that's not from behavioral health care, but I think is very telling. Louise cared about me. So this is Louise. She's a virtual nurse who helped people when they were discharging from the hospital after being medically admitted for a chronic condition. And patients who had Louise go through their discharge instructions had things to say like, "She cared about me." I wasn't given the quality of time in other hospitals that this lady gave me. With a computer, you can go slow, go over things again, and again and again and again, and she checks that you understand. And so I think that this highlights how, when you smartly design technologies, you can give people an experience where they will feel like they are really getting their needs met because they have the time. You can repeat things. It's okay. You can be infinitely patient and do whatever you need until a patient is satisfied that they understand what they're supposed to be doing. And as a result, in this study, 3 times as many people like the virtual nurse to the human nurse. So I won't comment on what the usual care system was at this hospital. I don't know it. And we certainly could say, well, that's because, you know, the ordinary hospital discharge procedures are so abysmal, which might be true. But I think then we also have to ask ourselves, you know, is any other place really that much different? So there's another study that also gives some hints that maybe we can smartly integrate technologies and do a good job of integrating the technologies with the humans that support them and do a better job. So this is a study where patients were provided with a mobile health app in addition to a standard weight loss treatment program that involved things like a weekly group treatment. And what you see is on the bottom line on the chart is people who got the mobile app and who attended the group, and they lost the most weight. And the 3 lines up at the top are people who got the app but didn't go to the group, and the people who didn't get the app. And what you see is it looks great. The technology was really helpful, but only if you were also connected to the human. So in the context of managing chronic conditions, depression, other serious mental health issues, what I've been thinking about is the way that health information technology should really facilitate the kinds of things that we really want to provide to patients, like adaptive interventions that account for treatment adherence, treatment responses. And so mapping out what an episode of care might look like and how the technology might fit in, we could start by saying that we should have patients and providers who are negotiating a care plan, engaging in some shared decision making. And there's a lot of ways that technology can provide patient education and can provide decision-making algorithms to help with that initial treatment plan negotiation. And then there's the meat of the matter, which is when patients are carrying out a treatment plan and they're outside of the office, they're in their own lives, and there's a lot of opportunities here, I think, for patient-facing technologies that can help engage people, empower them, maybe provide reminder systems, provide encouragement or rewards, provide alerts, maybe even identify if there's barriers or problems that come up. And hopefully, if we are smart about how we use technology, we might actually be able to get some information back about, hey, how are things going with that treatment plan we negotiated a couple of weeks ago? Have you been having problems? And we could get back some relevant data on if there are problems or barriers, or how people are doing. It went great, it went terribly. Right now we don't know until the next visit. And we can also have decision-making algorithms that help us to monitor and adjust treatment in a step care fashion so that we know, oh, if that didn't work, here's what I might try next. So these are a number of different ways we can think about incorporating technology into our workflows. And what I'd like to do is show you a little bit about how we're using some web-based technology in a collaborative care model. I won't spend a lot of time describing collaborative care. Many of you are familiar with this, but the idea is that into a primary care setting, we add in a care manager and a consulting psychiatrist in order to provide care where we're really being very proactive, we're doing outreach, we're using measurement instruments to treat the target, we're adjusting care for patients who aren't improving, and we have systems of providing accountable care where we really are monitoring outcomes. And some of the thinking that we've been doing is how would technology really fit in and enhance some of these kinds of tasks that we think are effective in improving patient outcomes. And there's a lot of them, so I won't go through all of them. But what I would like to show you is an example of using the patient registry that's a web-based tool, and how we can think of that in terms of supporting population-based care, making sure no one falls through the cracks, the treatment to target, which I just mentioned, and the accountable care as well. This is an example of the web-based patient registry that's in use in the statewide mental health integration program here in Washington State, as well as in the behavioral health integration program that's in our primary care clinics and a variety of other programs. And what you see is in one screenshot, you can quickly look at a whole group of people. You can see when they were seen, what their scores were on standardized tools, how long they've been in treatment, and other relevant information. And that can then be sorted, so you can identify people who maybe have high symptom burdens, or people for whom they haven't been following up. And you can identify priority cases and really focus time on those people who need more help, because the people who are doing great are doing great. That information can also be aggregated together. This is all fake data, so that's why it's all full of zeros. But you can pull together and get information about how's your healthcare system or program functioning as a whole. Are we hitting our metrics? How much of our caseload are we actually seeing frequently enough? In this case, 2 contacts a month is used as a metric. What proportion of our caseload is actually improving on their symptoms? And when you take this kind of information technology tool and match it into a healthcare delivery model that's effective, here's some examples of what you can learn. you can learn about the processes of care that you're delivering and see, for example, in the Team Care study, which was a randomized trial of collaborative care for patients with chronic diseases, that in the first 2 months of treatment, 10 times as many people who got collaborative care got their treatment adjusted because we had a healthcare model that prioritized adjusting treatment for patients not improving, and we had tools that helped us figure out who needed that kind of treatment adjustment. And in the statewide mental health integration program, another application of this is that when quality improvement efforts were put into place that were tied to those performance measures that I showed you and connected with pay for performance, the median time to improvement from depression was cut in more than half, which means that a whole lot of patients had a lot of depression-free months. And we were able to use a combination of the healthcare model with good technology to support it, to use data to improve quality and improve patient outcomes. So we've been thinking a lot about, with this patient registry, that's collecting information on how patients are doing over time, how can we really get this even further outside of the clinic and into people's lives? And so we've had a lot of interest in thinking about what would a patient portal look like, or how would we provide some kind of patient-generated data into our registry so that we can even enhance the ability for us to do this kind of work even more. And so I'll share with you one example of where we're hoping to head with this. And this is a pilot project that I've been working on, where we would be using a mobile health tool that we would give to patients that could collect information from them based on their self-reports about how they're doing with things like PHQ and GAD-7 that we're all accustomed to, as well as some check-ins about how people are doing with their medications and with their treatment plans, some brief psychoeducation that can be sent out to people, and the ability to use the phone as a sensing device to get some information about their location, activity, communication patterns, and then feed this information back to the healthcare provider. So what we're hoping to do is pilot this out in one of our clinics to start to understand, is this something that patients like and that care managers can use? And how does it fit with our existing workflow? We think it would fit pretty well because we have providers who are used to providing measurement-based care and using standardized tracking tools. And now they would have a window of what's happening to their patients in between visits and outside of the office. So we're excited to be moving in this direction and hope that we'll learn some useful kinds of strategies for better engaging our patients and really moving to the next step with this. So in covering all of this landscape, I think coming back from the promise of what the technologies might have, the valley of despair of the limitations of where we are right now, I think the reality is that we're still a long way from really using a lot of these very exciting technologies to the advantage of many of our patients. But we know what the process is. We have new sources of information, and it'll be a lot of work to turn this into things that are clinically useful and improve patient outcomes. And we'll need advances in methodology as we're able to collect information in this kind of continuous way from people. We'll need to be validating measurement techniques, but what an opportunity to really learn about people's behavior and activity in their day-to-day lives instead of relying on self-report. We need to think about how to merge different streams of information, just as we do where we take a patient history, we get collateral information, we might get some health records, we do a mental status exam. We bring that all together in our assessments of patients. And now we have new streams of information that can also be part of that assessment. We need to understand more about how technology is affecting health and health services, and I think that that's both for the good and the bad, and we should always be aware of unintended effects that could be happening out there. We also have the opportunity to think about completely different kinds of interventions for patients that don't have to be based on brick and mortar clinics and 50-minute therapy hours. They can be delivered flexibly in very brief little niblets or bites. And we may find that there are actually more effective ways to motivate behavior change that don't involve getting people in every week for an hour at a time. So those are, I think, opportunities for us to be really creative in thinking about what might actually work for our patients if I don't have the constraint of having to do this in the office. And then certainly in terms of implementing new models of technology-enabled services, even when we get good models of providing care, we know that there's a lot of barriers there, not the least of which are financial and organizational. And so we need to think about, once we start to learn how to bring these technologies in and have good examples of improving patient outcomes, what's going to turn that from what we know into what we're doing on a routine basis and every day to improve the outcomes of the patients that we see. So with that, I would like to give a big thank you to research mentors here in this department, Wayne Caton, Jürgen Unitzer in particular, as well as folks who were very important in shaping my approach to these problems when I was back in Boston, Maggie Allegria, Richard Frank, and others. And I thank you all for your interest and attention today. I think we have a little bit of time at the end here. If anyone has any comments or questions, then yes.
Something like e-care that a lot of providers have signed up for it and allowing the patient. So again, a form of technology and then there could be similar apps which could directly have their results uploaded onto our system.
Yes.
But I'm always like, my concern would be like, if we're getting such frequent feedback, and do we have a system in place where we could respond to any, because a lot of patients might be in crisis situations, but not enough to go to any emergency room or something, and then that will also require that we should have something in place to intervene right away and do something about it.
Mm-hmm.
Right? So it's kind of, yes, it's good to know that they're going through such phases or whatever is happening in their lives, but at the same time, are we well equipped to handle, and even with e-care, I feel like, okay, what if I'm getting emails every day from someone, needy patient asking for some meds, whatever, and I'm kind of stuck because I asked for it and now I have to respond, and then,
I think so. So the question is about, given that we have some technologies like e-care with emailing patients, and they're sending us this information, what if it's too much? Oh my God, it's information overload. And I think you're right. I think what this highlights is that our existing models of service delivery are not well organized to incorporate this kind of information flow. And there's been some research in the primary care arena where primary care providers really feel overwhelmed and intimidated by the excess amount of information that's coming in. See, there's a comment. And so I think that we need to think about this information similar to how we think about telephone calls. I mean, it's true that there's less of a barrier to email someone than there is to call. But if we don't have a good system for interfacing with patients out of clinic, that applies to phone calls as well as emails, as well as any other kind of channel of information. We need extenders. And in the medical system, that's much better developed by smartly using team-based care and having medical assistants and having nurses who can try to triage and respond and incorporate information. And we're not there in the behavioral sciences. I think that we have a ways to go. And you're right, until we have models that can really incorporate information in a proactive way, it's a real challenge. And I think that's one of the problems that we need to be addressing, is trying to get the technology and the service models to line up so that we can do things well and smartly and not be overburdened or burned out by information that's coming at us that we don't have a workflow to process.
do you possibly see the sim sensei to be used in the future once it's more advanced for like suicide prevention, crisis, maybe even drug addiction counseling?
So the question is about the virtual therapist, the sim sensei, and what might be the potential future applications of that. You know, I think that we should consider the possibility that it could be used in a variety of different ways. And in particular, where providers are in short supply or you need someone kind of and nobody's available. Right now, I think this is something being developed very much without a lot of involvement of healthcare providers. I'm not sure kind of the composition of their team. So it hasn't really been, I think, used in clinical settings at this point in time. They're working on getting the algorithms right to detect facial expressions and things like that. I think it's very exciting to think about, you know, how it might be applicable in a whole variety of ways once we're at a point where we can start using it in real world settings and testing and learning and seeing also. I think this is an example where we have to be wary of unintended effects, is that we should be careful if technologies are actually encouraging people to get a less effective service. And so if there are ways that technologies are keeping people out of the healthcare system who might otherwise be coming into it, that could be a red flag. And so we need to think about that, because the technologies can get to a lot of people we can't reach. But if they're somehow keeping away people that we could have been reaching, then that might not be the optimal use. So I think there'll be a lot of opportunities and challenges to look at those things. Did you have one?
Yeah, I was just thinking that one of the problems, along with what Kokil was saying, is that like administrative ideas about our workflow are still very traditional. Like they want us to see patients all the time, and we don't have time to handle phone calls, much less records, and certainly much less whatever is going to come into us with an unfiltered patient communication system. So it seems like there's a lot that's got to happen at that level as well.
Yes. So the question about the delivery system being organized in a very traditional way that's primarily paid for still through fee-for-service mechanisms that are based on provider time being the only thing that's reimbursed, and not having reimbursement for all these other important things that are part of delivering effective care for chronic conditions. So I think you're right that that we're seeing some movement in terms of health reform to try to reorganize some aspects of service delivery with accountable care organizations and other kinds of possibilities where I think we're all hopeful that somewhere out there there's going to be money in that to do all these things that we think are really important and currently not reimbursed. And the direction that takes, I think, will also have a very important effect in influencing how much we can use some of these really smart technologies. Because if we can't put in place a model where we can incorporate that kind of workflow, then we're really going to be in trouble, and that'll limit our ability to really leverage the technologies.
Okay, well, thank you very much.